Good morning, good afternoon, good evening from whichever part of the world you are watching us. I'm Dr. Shivakumar from the Structural Heart Division of Madras Medical Mission, Chennai. And I would like Dr. Anselin, one of my colleague, to give the clinical details of this interesting patient who has got a mitral paravalvular leak, which we are going to address by a transcatheter procedure today.
Today's patient is a 50-year-old male who was diagnosed to have severe rheumatic mitral stenosis and underwent mitral valve replacement using 29 mm tilting disc mechanical processes known as TTK Chithra valve in 2010. He presented with progressively worsening dyspnea on exertion, orthopnea, and paroxysmal nocturnal dyspnea for the last 2 years. He is well built with weight of 62 kg, vitals were stable, no cardiomegaly, normal S1 with a prosthetic click, normally split S2 and a grade 4 pansystolic murmur heard at the apex. Chest X-ray is showing mild cardiomegaly with CT ratio of 60%. The prosthetic mitral valve is seen with evidence of left atrial enlargement in the X-ray.
After I do the septal
ECG
puncture,
is showing normal sinus rhythm with heart rate 90, PR 200 milliseconds with evidence of left atrial enlargement and incomplete left bundle branch block. This is the transthoracic echocardiogram showing a dilated left atrium and left ventricle with mild LV systolic dysfunction, a well-functioning mitral valve prosthesis with moderate to severe medial paravalvular leak. The mitral inflow gradient was measured 7 mm of mercury mean with mild valvular regurgitation, and the TR was mild with an RVSP of 24. Parasternal long axis view showing moderate to severe medial paravalvular leak and mild aortic regurgitation. This is a transesophageal echocardiogram showing posteromedially located paravalvular leak. This is the TE image showing posteromedially located paravalvular leak, and this is a 3D zoom image of the medial paravalvular defect with the color Doppler.
Thank you, Dr. Anselin. So what you have shown is a paravalvular leak that is located quite medially, very close to the intraatrial septum. And now Dr. Srija is live with the echocardiogram. Srija, can you enable the color Doppler to show that medial paravalvular leak? Right now we are showing it beautifully. The leak is seen bang on the middle of the screen, and that's a wonderful demonstration. The peculiarity of this valve, this valve is called TTK Chithra valve. It's a single leaflet prosthesis. The disc is made up of ultra high molecular weight polyethylene. There is no radio opacity of this disc. This disc has to be analyzed completely only by echocardiography. The restriction of the movement of this leaflet has to be analyzed only on echocardiography. We cannot see it on fluoroscopy. Even though it is similar to Jock-Shilley or the Medtronic Hall prosthesis, the other similar single leaflet prosthesis, this particular leaflet is totally radiolucent and will not be visualized at all. I think if I remember, in somewhere around 90 degree, we were able to see the valve leaflet perfectly. Can we zoom on the valve and show that maximum excursion of the leaflet? Yeah, here the valve is seen nicely. We can probably zoom on the valve and get it magnified so that we are able to see, and we can freeze it now when the valve is fully open. Perfect. So it's almost around 80 degree opening angle, and we are able to see that closing. So this is the valve leaflet mobility, and this has to be ascertained only by transesophageal echocardiography. It's a non-radiolucent disc. What you're seeing there on the screen is the echo navigation fusion of the images. We are now visualizing a marker, red marker on the intraatrial septum. This is a little postero-inferior, and an yellow marker which is a little posterior. I have taken it far away from the mitral valve prosthesis so that I will have a working angle for manipulating my catheters. So right now we have an 8 French transseptal sheath that is already placed in the left innominate vein, and we are having a standard BRK1 needle which is going through that 8 French Mullin sheath. This Mullin sheath is now going to be brought down to the intraatrial septum. We are progressively coming down to the point, give some sedation, to the point where my echo navigation I have plotted. So I'm coming to the region of the echo navigation. I want to direct it a little posteriorly. It's going too posterior. I'm reaching the target. I'm indenting the septum. I'm very posterior and I'm very inferior. We can appreciate that I'm very inferior. Can you show the tip of the needle on X plane also, Srija? I'm seeing on the Y plane, X plane also. So this is the place where we are indenting the septum. Can you show that a little bit better? I'm able to see the indentation. At this indentation, I'm giving a puncture. I have entered into the left atrium. You are able to see the needle in the left atrium. I'm injecting my contrast into the left atrium, and you are able to see the floating of the contrast. At this moment, I advance my needle, I advance my transseptal sheath. It's completely hidden by the T probe. So let me move the image. Can you go LAO? I'm in the LA. I'm advancing my transseptal sheath a little bit more, and I'm taking out transseptal needle. We have already given heparin 6,000 units, that is 100 units per kilogram body weight of unfractionated heparin at the beginning of our vascular access itself. Sometimes before transseptal puncture, we don't give heparin, or we give a very small dose of heparin because of a possibility of unfortunate transseptal puncture related injury of the heart. But since we are doing completely on an echo guided system, we decided to give full dose of heparin. Now I am connecting to left atrium. Can you show the left atrial pressure? At this point, we are planning to change over to a steerable sheath, 8 French Fustar. We have a left atrial pressure of around 12 millimeters of mercury. Can you appreciate the transseptal sheath going through the atrial septum and try to see where the transseptal sheath is crossing over? If you move up and down, you should be able to, I'm able to see it on the Y plane. Yeah. On the X plane also. Probably it may be a little inferior by pushing it inside. We just wanted to see where we are entering. So at this point, let me get the right coronary catheter. We are planning to enter into one of the pulmonary veins and change it into a Fustar sheath. A Fustar sheath is basically a deflectable sheath. It's something similar to the Abbott's Agilis sheath. Abbott's Agilis is a 8.5 French sheath, whereas a Fustar is available in multiple sizes. So we may be using, this is the left atrial entry. So I'm trying to get the wire out, coiling within the left atrium. I'll try to see if I can enter into the pulmonary vein. Instead of pulmonary vein, I'll try. You can see how much the left atrium is aneurysmal. Can we get the super stiff wire? Amplathe super stiff guide wire. So using the Amplathe super stiff guide wire, we will be now getting the Fustar sheath, which is a deflectable sheath. Show the aortic pressure. I have to get the catheter out. This patient had paroxysmal atrial fibrillation on and off. Right now seems to be having some form of a stable rhythm, even though we are not appreciating a clear-cut P wave. I wonder if it is a flutter with a 2:1 block. So can I have a dilator? So this is a Fustar sheath, which is a steerable sheath. We have now put it into the left atrium. I'm now taking out the dilator. I'll now flush it out. So this sheath has got a property of flexibility. So right now, as I talk to you, I'm able to flex the sheath. I'm able to extend the sheath. What I will do is I will flex it. And at this point, I'm going to bring sheath down towards the intraatrial septum. So I'm facing it towards the mitral valve and bringing it down towards the atrial septum. Can you enable 3D on the 3D zoom on the sheath and show whether I am directing it towards the paravalvular, towards the mitral valve? We are able to see now the bend of the transseptal sheath. So right now I am bringing it down to make it face the mitral valve. The position is looking fine. Can you go to RAO? We are planning to enter the paravalvular leak. The length of this catheter is short, and so I will need 120 centimeter right coronary artery catheter. So currently what we are planning to do is direct the echo navigator more towards, I'll make this screen become larger, advancing the guide wire from this sheath. Okay, it's facing down. I need a little longer catheter. It's going through the valve into the mitral valve. So I will, that's a good anchor. So you are holding the sheath. I'm taking out. So we are advancing the catheter. I'll try to make the Fustar bend a little bit more, and I'll bring the Fustar more closer to the intraatrial septum. At this point, it's facing a little bit more inferiorly than what I desire. Can you get me LAO view and go cranial now? I have crossed the paravalvular leak, and now I'm trying to see if I can advance the guide wire into the ascending aorta. So which is it has done. So at this point, if I do a fluoro, we can appreciate here, this was my echo navigation marker. This was my transseptal marker, the red marker, but because of the change of position, there is some offsetting. And here is the echo navigation marker through which I have actually entered. So this is the gap between the prosthetic valve metallic ring and my leak. So at this point, I am slowly advancing my right coronary catheter deep into the left ventricle and making a turn. Now I want to come back to the RAO. At this point, we are going to switch it over into Amplathe super stiff guide wire. I'm trying to get it facing towards. So now I'm taking out my Thermo guide wire and changing it into an Amplathe super stiff guide wire, which will give me a little bit more strength so that I can advance a stronger catheter, like a guide catheter, into the left left ventricle. It's getting tilted up. So what I will do is, I want more of the, I am bringing it very low. I'm again trying to advance the superstiff guide wire. And basically, this is now, we are trying to reduce the curvature. Can we get it out? Feed the wire and get it out. So now again, I will flush this system. We will now take a 7 French guide catheter on this Amplatz superstiff guide wire, advance it into the left ventricle. Dr. Pramod Sagar has also joined me for this procedure now. Now I'm advancing my 7 French right coronary artery guide catheter, which is 100 centimeters long. The problem that we faced a short while now was the length of our catheter was inadequate because push-star is very, very, very long. This is the maximum that I can go. I'll try to advance. Almost my push-star is on the paravalvular leak. So I'm going to record a cine. So here what we have done is we have advanced the push-star closer to the paravalvular leak. We have advanced the guide catheter deep into the left ventricle. And I'm leaving the Amplatz superstiff guide wire. In the meantime, I'm flushing my push-star sheets. Now the plan is to go retrograde and get another, I want the Judkins left catheter, another crossing, so that we have two parallel catheters, one through the antegrade approach and one through the retrograde approach. We are getting our Judkins left coronary catheter, go into the ascending aorta. We have entered into the ascending aorta. Can you come down to that RAO view? We need to direct the catheter towards the paravalvular leak. So I will use now the LAO projection. So at this position, I am trying to cross. I have already crossed the paravalvular leak. Fluorostore this and demonstrate this again. What we have done is Judkins left coronary catheter. So we are directing it towards the paravalvular leak. This is the paravalvular leak. So we are directing it towards the paravalvular leak. And we are crossing from the left ventricle into the left atrium. And I know that it is in the left atrium because I am entering into the pulmonary vein. Come back to atria, come back to AP view. So now we are trying to advance this catheter across the paravalvular leak. Again, we are facing a short, the catheters. Can we take that 6 French right coronary artery catheter? Since the standard Judkins right coronary catheter was 100 centimeter and it was not able to cross the paravalvular leak and enter into the left atrium, we are now taking Judkins right coronary catheter, which is 120 centimeter long. We are advancing because of the angulation. It's facing some difficulty. It's just crossing. We can appreciate that it is just at the edge of the paravalvular leak. Can you go back to that LAO view? It's too much of tortuosity of the entire turns. Let me soften out those loops. It's a sharp bend into that aneurysmal atria. I have entered into the left atrium. I am advancing my catheter into the left atrium. I will now bring down the looping. So at this point, the next step will be to exchange this into another guide catheter. So for that, I have to take out this superstiff guide wire. Come back to RAO view. So we are now taking out this Amplatz superstiff guide wire that we have already placed. And we are advancing that Amplatz superstiff guide wire into the retrograde arterial catheter. We will get ready a 6 French right coronary artery guide catheter, but that needs to be longer. Do we have any longer guide catheter that is a little more than 100? And we don't have, right? This is a practical problem that we'll get because the patient is tall. Let us try to see whether the stiffness of the Amplatz superstiff guide wire will enable us to get the 100 centimeter right coronary artery guide catheter. While we are waiting here, let us take the Amplatzer vascular plug on the right. We decided, Pramod, for a 12 millimeter Amplatzer vascular plug. So a 12 millimeter Amplatzer vascular plug. I'll demonstrate the Amplatzer vascular plug. It is a 3-lobed device. It comes packed with its own cable. So there is a port to flush the Amplatzer vascular cable. And now at this point, I'm taking it out. This is the screw-in cable. Come back to RAO. Push-star sheath is in a little precarious position. We see that it is. Now I am reducing the angle on it. The tendency for any large device that goes through this push-star sheath will be to push it towards the roof of the right atrium rather than getting directed towards the mitral annulus. So I'm now opening out one of the discs to secure that I will not lose this position. So at this point, I am locking the sheath. So now we are going for the reason why I am opening out this Amplatzer vascular plug is the catheter will have a tendency to be thrown out of the left ventricle back into the left atrium if I don't have a plug that is already placed there. So right now what we will do, the next step will be, is it bleeding here? Now I will take a 6 French right coronary artery guide catheter retrograde. Now I am advancing the retrograde catheter. This is going to face the same challenge like, oh, that's good. This Amplatzer super stiff wire has actually facilitated a smoother passage of this catheter from the left ventricle, from the aorta to the left ventricle to the left atrium. So Srija, you are able to confirm that there are two catheters going through? Yeah. I'm able to see one. Okay, that's wonderful. Our plan was to put in 8 millimeter vascular plug 2 on the retrograde catheter. So can we get an 8 millimeter Amplatzer vascular plug 2? Yeah, the 2D image is good. The 2D image was showing the two catheters. There are quite a few ectopics. The moment I get my retrograde vascular plug, this is flushed from. There was a question from one of our visitor, Dr. Edwin Francis, has come from another state, Kerala. The question is whether one single device would have been enough. Yesterday, during the course of evaluation of this paravalvular leak, we found that anteroposterior dimension was between 11 to 12 millimeters and the sideward dimension was about 8 millimeters. We discussed about the possibility of choosing Amplatzer vascular plug 3, which is now also called as the paravalvular leak device 3. The largest Amplatzer paravalvular leak device is 14 by 5. I'm trying to get it up. What I'm planning to do is get one of the plugs, come closer to the mitral valve. Now I have two plugs, one from this side and one from that. We'll target on the larger plug. I want the disc to be made exactly profiled. Give a cranial or a caudal on this, make it like a flat disc, absolutely in profile. Perfect view. We are now working on, I'm advancing the middle belly. I'm withdrawing. I'm trying to position the middle belly across the leak. At this position, I'm slowly peeling back. Let us now see the 2D picture. Since the paravalvular leak is getting closed, possibly there is a lot of spontaneous echo contrast. Shall we check one ACT right now? It's about 40 minutes from the time we gave the heparin at 9:35. So now it is 10:15, around 40 minutes now. Around 90 degree, you are able to see the valve disc very nicely.
Almost closed.
Yes. So can we see at 90 degree, demonstrate the valve leaflet, make it magnified, full excursion. Yeah, I think its full excursion is seen. We understand that there is atrial fibrillation. Dr. Pramod is getting an activated clotting time organized. The valve leaflet mobility is normal. We have deployed one of the discs. Now I'm going to come from the second disc, magnify this now. Are we able to see by 3D second disc, Srija? I think we have to cut down the gains a little bit in order to see. Now at this point of time, I will now see it. See, on fluoroscopy, the larger device is more anterior. The smaller device is more posterior and inferior. And the smaller device, we are able to see two discs onto the left atrial side, and one of the disc is on the right atrial side. Slightly give a little bit more cranial or caudal. Wonderful. Magnify this. Now I am taking a cine run. We are able to see that this screw end is completely here. Let us see the 2D. There's a lot of spontaneous contrast. I would like to now see the valve disc, whether it is moving perfectly well. It's clearly the patient is in atrial fibrillation. The valve leaflet mobility is normal. Now at this point, let us also try to get a transmitral gradient on the valve. Magnify the screen fully, lower the scales, lift the baseline up. It's not crossing 1.5 meter the peak velocities. It's a peak of 6, so a peak of 8 and a mean of 3. So it's not very high. So it looks nice. What we'll try to do now is, now let us get a 3D of the close-up 3D view of both the discs. That seems wonderful. We are able to see. Now we can cut down the gains a lot so that we can, we are able to clearly see what we are holding from the atria is more anterior, and what we are holding from the ventricle is more posterior. So at this point, since the devices are stable, I am releasing them. I'm releasing first the antegrade device. So that I have taken it out. Now I get my left atrial pressure free for assessment. I'm going to assess the left atrial pressure now through this guide catheter. There's a lot of spontaneous echoes because of the atrial fibrillation, which I am planning to electrically cardiovert. What do you feel, Dr. Pramod? Even though the left atrial size is about 8.5 centimeter, this patient's previous ECGs at some time has shown sinus rhythm, and so would like to give the benefit of doubt. Now, there is no paravalvular leak. There are some valvular leaks within the valve housing. The paravalvular leak is totally completely gone, right? Okay, that's a good sign. I think the devices are quite stable now. Anyhow, let me release the, or do you think we will electrically cardiovert and then release the second device? Dr. Pramod has got a point that if I do an electrical cardioversion, whether the devices that are freshly placed, is going to be a little bit unstable, and so is going to be a threat of embolization. I feel that we have very stable device position, and hence the patient should be able to tolerate, get the transmitral gradient on, put it on. Actually, the left atrial pressure has come down from the starting of the procedure somewhere around 15 millimeters of mercury now to around 10 millimeters of mercury. Put it on 10 scale. Now we are able to see that there is hardly any transmitral gradient. Let's get a electrical cardioversion 200 joules single shock synchronized and give a broad vector, Prabhu. We can keep the sternal paddle beyond the right mammary region and that one towards the apex. 200 joules. Okay, so supplement heparin. Okay, ready? 200 joules. It gave a very delayed shock. Yeah, we are seeing some beats in sinus. Let me see. Let me wait for some time. Srija, in the meantime, now we can look at the device, whether they are stable. One of the beat was having preceding P wave to RAO on the same projection here. Because of long-standing atrial fibrillation, there could be some degree of sinus suppression also. We are able to see the second device. So now I am releasing the second device. Now I am pulling out my catheter into the aorta. Now this is aortic pressure. Now everything is to be identified only on echocardiography. Let us get the echo systematically analyzed. The left atrial pressure is about 10 millimeters of mercury. So I am pulling out the left atrial sheath out into the right atrium. Now the catheter has come off. Show AP fluoroscopy of the Fuster sheath. Now I will try to reduce the loop and make it straighter. Can we go back again on fluoroscopy? Show me on RAO view the two discs. Make it magnified. Here we are able to see the two plugs interlocking with each other. Can we see in an orthogonal projection something like elevocranial? Srija, are we getting good valve leaflet mobility?
Yeah.
Okay. Request you to take this transesophageal probe through the head end of the patient. Clearly, the two plugs are interlocked and are lying on the medial side of the screen. So now we can get back to AP projection. Can you show the aortic pressure on appropriate scales? The blood pressure is stable. Can we increase the P voltages? The voltages slightly increase. If it is possible, give a 6-lead ECG. We have a 6-lead ECG format so that we can see more number of beats. You can change the pressures to 400 scales. So it's clearly in sinus. I think let us do the last checkup, Srija. You have to now give the final verdict. What we want to say, still there is a lot of spontaneous contrast. We have topped up the heparin, 6,000 initially, followed by, I want another 6,000. So that means give another 4,000 more. ACT was 120. It means a full top up of the heparin. Give 6,000 once again.
Completely
The paravalvular leak is fully sealed. That's nice. And can you show us the valve leaflet mobility on a 90-degree view? That's a beautiful demonstration of the valve leaflets. It's moving now far better than what it was before. The range of mobility is far better seen, probably because the rhythm is very regular now. So we are able to appreciate it far better. What is that? That's within the valve housing. Magnify that. Within the valve housing, there is a leak. So there is a valvular leak. The problem about this particular valve is that it is an ultra high molecular weight polyethylene. 14-year-old valve, some amount of degeneration of the disc may be there. But we have clearly documented that the left atrial pressure came down from around 15 to around 10. And the paravalvular leak is fully gone. This valvular leak was very significant. This spontaneous echo contrast will not be there. The spontaneous echo contrast indirectly indicates that there is some amount of stasis of blood in the left atrium. And that is a sign of efficient closure of the paravalvular leak. Let us see the tricuspid valve also. The tricuspid valve is seen very nicely. Moderate tricuspid regurgitation, and if we Doppler it for getting the RV systolic pressures, it's somewhere around 2 meters per second. So maybe 18. There is not much of pulmonary hypertension. Probably we need to work on the anticoagulation and ensure that the patient is adequately anticoagulated. This is a patient with atrial fibrillation with a mechanical prosthetic valve, which is of the older generation. And hence probably we should try to aim at a INR level between 2.5 to 3.5. We have to appropriately give the dose of Coumadin to match the INR levels. The vascular access closure will be just by manual compression. It is a 8 French on the vein and 6 French on the artery. I'm taking out the guide catheter that was in the aorta. We don't have any vascular hematoma here. We'll flush both the lines. PA pressure was normal pre itself. And now you are getting RV systolic pressure of about 18 plus right atrium, which is quite low. Closure of the paravalvular leak has been done reasonably well with normal mobility of the leaflet. In fact, this valve is projected only on echocardiography. I just want one last 90-degree view of the prosthetic valve leaflets. Yeah, make it magnified on that. In fact, even in the echocardiographic screen, we are able to see a small sinus P wave. The patient has assumed sinus rhythm. Probably have to maintain this with some amount of amiodarone. If I remember correctly, this patient is already on some agents for heart failure that includes sacubitril, valsartan, and a tiny dose of beta blocker as well. Is that right? So I think we will continue that sacubitril, valsartan, and we will continue the beta blocker. We will optimize the coumadin in order to get an INR level between 2.5 to 3.5. Add aspirin. The coronaries were normal. Can you show the two coronary angiograms that we did at the beginning? Yeah. So this was the right coronary artery, which was a dominant vessel. There was no atherosclerosis. And there was a left coronary that we shot. The left coronary artery was bifurcating into LAD and circumflex. The LAD was a small vessel, but the circumflex last OM was a very large vessel. And there was no coronary atherosclerosis as well. With this, we come to the conclusion of this session. So this was a demonstration of a medially located paravalvular leak in a 14-year-old single leaflet mechanical prosthesis where the radio opacity of disc was not there, forcing use of echocardiography to assess the valve leaflet mobility. We performed the paravalvular leak closure by combining echo navigation, which means fluoroscopy guided by echo navigation, and we are able to clearly see that the paravalvular leak is completely closed off, and both the devices are seen very clearly. One last 3D of that localized 3D zoom of that particular. So this is a 3-dimensional zoom picture of this paravalvular leak. Wonderful. Now if we slightly reduce the gains, we see it better. Yeah, we are able to see the valve leaflet and the two discs. The anterior one, which is near the head end of the patient, we are able to see the patient's body mark also. The head end of the patient is the larger 12 millimeter device, and towards the posterior end was the 8 millimeter. Leak was originally looking a little crescentic or oval with a long axis dimension of around 11 to 12 and a short axis dimension of around 8. And so probably these two devices are plugging it in the appropriate position. In fact, now the 3D is also showing the valve leaflet mobility. The valve leaflet, the direction of movement is actually perpendicular to the devices. It's opening and closing in an anteroposterior plane. We are satisfied with the result.